These are some of my conflicts of interest. I would like to share with you some current concepts in the management of CMC joint arthritis. We know that in terms of prevalence, that basal joint arthritis of the thumb is very common, and that a third of all women and a fifth of men in their fifth and sixth decades will go on to develop arthritis at the base of the thumb. An elegant cadaveric study by Richard Eaton has shown that X-rays underestimate the true incidence of arthritic change, and that osteophytes are seen long before cartilage loss and associated scaphotrapezial changes are common. So how does this affect individuals in the earlier stages? There are issues with activities of daily living that involve the thumb. And then later on, as the disease progresses, you end up with a full house with small necking of the thumb with a full-fledged adduction deformity, which causes significant issues. Now, we know for a fact that there is clear, unequivocal evidence to suggest that trapezectomies do work. And over the years, the humble trapezectomy and its many iterations have stood the test of time. But there are some significant issues, and these have really been the impetus for further research. People who do perform joint replacements speak to a quicker recovery, better grip strength, and very often use the term that the patient ends up getting a normal thumb. So with this in mind, we decided to conduct a survey within the UK looking at current practices, and there was no surprise to see that most consultants would go on to perform trapezectomies or slings. But what was interesting was that there was a significant number of people who currently are performing true arthroplasties of the base of the thumb. What was even more interesting was amongst those people who did not do these joint replacements, a good number would be keen on following this going forward. So what's happening in Europe? It does look like the trapezectomy and LRTI has flattened in terms of trends, while joint replacement prostheses appears to be the go-to procedure. So is there any proof within the literature to support this change in practice? Does the trapezectomy suddenly not work at all? With this in mind, we decided to have a closer look at the problem. It's always useful to look at the timeline, and like with most joint replacement related issues, our history here with this particular topic also starts with the humble silicone spacer. The 1990s, right up to the beginning of 2010, saw the usage of the modular anatomical uncemented prostheses. And to this group, I would like to add a new group, which is the dual mobility group. And this is an important development, and we shall talk about this a little bit later in some detail. Most systematic reviews, unfortunately, without exception, have looked at the modular anatomic non-dual mobility prostheses, and hence most of the literature that we get to read is related to the same. The Electra prostheses is the prosthesis in the UK, certainly, with the longest follow-up. And because of its metal-on-metal nature, there were varying results, starting with 90% in a paper published in 2014, and a similar paper, RCT, which showed a 72% survival rate. Our surgeons from Swansea have arguably a significant experience with this particular prosthesis, and they published their results in 2013 and a subsequent update. And they found that there was significant aseptic loosening of the cup, as well as osteolysis, causing needing revision surgery. The other prosthesis which is done in large numbers is the RPE, and to a large extent, this demonstrates some of the conflicting papers that have been published on the subject. So I'd like to draw your attention to one particular review, and if you were to read one journal on the subject, I would probably look at this particular volume, because in the beginning of the journal, where devoted to this particular topic, there is a paper by these authors, Ferrero et al., who demonstrate that this particular prosthesis worked very well, 93% at 10 years survivorship, which is very, very reasonable. And then subsequently, just a few pages later, in exactly the same journal, you have a group of senior authors who publish a survivorship of just 85% of 10 years. And then they go on to suggest that a usage of this particular implant should be used with caution. So what should the jobbing hand surgeon or limb surgeon do when faced with conflicting literature like this. There have been papers in France, such as the one published by Alain, looking at 110 prostheses. Once again, issues with dislocations, but overall showing a 95% survivorship at 10 years, which is quite close to some of our survivorships of knees and hip replacements. When you look at the systematic review that I alluded to earlier, the Maya prosthesis, as you can see here, tends to do quite well. And the Movis really is a dual mobility prosthesis, and it would be unfair to compare the Movis with the other prostheses because of the nature of the Movis prosthesis itself. But loosening and dislocation continue to be issues. And this is why the dual mobility prosthesis is important. We need to look at it more carefully, because this represents a paradigm shift in the biomechanics of this particular prosthesis. So what do we have with the dual mobility prosthesis? We have a large fixed press fit acetabular cut with a bipolar femoral component. As you can see here, you have movement that occurs at two distinct articulations, which allows a greater arc of movement. And because of the fact that the effective head size is much larger, it allows more stability. Additionally, because you're using a larger head size, you find that the jumping distance, or the distance at which the dislocation will occur, becomes greater, as well as the fact that the force is now distributed between two articulations, thereby theoretically certainly reducing the shear stresses at the level of the acetabulum, thereby implying that loosening may not occur. However, we have to remember that now there are three articulations at which wear can occur, including trunnionitis, as you can see here, just as you would see in lower limb prostheses. Our lower limb colleagues have managed to get through this with the help of a chamfered type of acetabulum as against to a hemispherical acetabulum. And these may be developments that might occur with the prostheses going forward. Furthermore, what you have is the high density polyethylene liner. This is another development which has superior wear patterns and can be used for the purposes of this particular prosthesis. And it remains to be seen whether or not this would work going forward. However, there's no going away from the fact that dual mobility will have its own complications, specifically the possibilities of dual mobility dislocations, which can be difficult to treat. Furthermore, although this has not been reported, this may be something to look forward to, specifically notching. Clearly, there needs to be a significant amount of research that needs to be done, and a sweet spot will have to be found in terms of head size. How fair is it to compare the hip replacement with a joint replacement when it comes to outcome, given that we have a saddle-shaped joint at the base of the thumb, when you have a simple ball and socket type arrangement at the level of the hip? Furthermore, in a hip replacement, where the hip has a much smaller representation within the cortex as regards the thumb, and hence a small issue with the thumb is interpreted as catastrophic within the homunculus. However, there's no going away from the fact that comparisons will be unfair, unjustified, but inevitable. And this is really where the dual mobility prosthesis comes in. And the literature is quite different when you look at the papers that follow. So let's look at the touch prosthesis, which is relatively new. The satisfaction rates are very high. This is something that was seen in successful papers of prostheses, even with the non-dual mobility. But what is different is that the dislocation rate is low, and a new set of complications appears, namely decurving stenosynovitis, trigger fingers, chronic regional pain syndrome, and cup loosening, most of which is very often attributed to poor technique. Looking at the Movis, which is another prosthesis, which is quite similar, which has these micro stems, which are the new stems. These allow you to fuse the MCP joint if required. Once again, excellent results in published literature, albeit early intermediate results with no dislocation. Similarly, with the Maya, This is not a published paper, but this is personal communication from the surgeons from one of the tertiary units called Oswestry, not far from Wrightington. And the prosthesis seems to be doing well. And the survivorship needs to be creeping up. So there is a tendency to blame the implant, blame its design for all the failures that occur. There's no going away from the fact that careful surgical technique, precise instrumentation, and extensive soft tissue release is important to follow. Patients tend to go back to heavy repetitive work despite what we tell them. And often when we do these in older individuals, we are faced with poor bone stock. And when we compare this to the extended learning curve that is required, it is no wonder that the earlier anatomical modular prostheses were faced with failure. When we compare the trapeziectomy with total joint replacements, there are numerous papers which are more or less retrospective cohort studies of short duration. The only randomized controlled trial that has been published, unfortunately, had to be stopped due to the high rate of complications with the Electra. When you look at the summary of outcomes, all the soft outcomes in terms of patient satisfaction and scoring, patients tend to do very well. But pain relief and a quicker return to work and issues surrounding activities of daily living tend to occur sooner in patients with joint replacement surgeries. However, there is a price to pay. And you can see I've had to use a smaller font on the right side when it comes to complications. You have nearly double the number of complications that you had with trapeziectomy when you look at this systematic review. And there's a whole lot of newer complications that have occurred, which did not occur with trapeziectomies. So looking at the summary of outcomes, there is no evidence to suggest a statistical superiority of one technique over another. In this age of central procurement, in order to justify its use and its cost, the total joint replacement needs to be significantly better than a trapeziectomy. Because not only do we have to consider the implant cost, we have to think about the greater surgical time, and we need to find out precisely whether or not the theoretical benefits of early recovery and better long-term pinch are offset by the increased risk of failure, such as loosening or dislocation. Certainly with the dual mobility prosthesis, this does not appear to be any longer an issue, but there are newer complications which have occurred. There are no benchmarks for acceptable or poor survival rate, certainly when it comes to the UK. Case series tend to be prone to publication bias, as we know, and clinicians and editors are more likely to publicize results if they are good. What we do need is prospective data registration, something like a national registry with planned long-term follow-up examinations with reduced dropouts to improve the accuracy of estimates. And without doing that, I think it will be difficult to prove superiority of one procedure after another. And with that, I'd like to conclude and hopefully welcome all of you to Wrightington at some point. We are 11 consultants and we offer all forms of upper limb surgery within the northwest of England at Wrightington, which, as you all know, is the home of the total joint replacement, which was invented by Professor Sir John Charnley nearly 50 years ago.